It's 9:35.
Good.
So is it your dinner time there?
Yeah.
Okay. So for everyone from Middle East, we have made Turkish bread today for dinner.
Yeah.
Thank
Okay, so this is a very long talk. You'll cut me short when it is 15 minutes.
Okay.
This is the only we have.
Sorry?
We'll give
And
you
this is the only we have the time limit.
Yeah, sure. So most of the stuff which I'm going to talk about has been covered in the textbooks. One is by the ASSI and one is from the MISAB, that is Minimally Invasive Spine Society of India. So this is a lady who is extremely obese. You can see her. She has a high BMI, which is about 38. And you see she has significant leg pain. This is post-operative image. She is smiling a bit. Otherwise, she was in significant agony. She had left-sided anterior thigh pain going down to the shin. And on the left side, you see here, she has a disc on the left side. It's an extraforaminal disc, and these patients tend to be extremely in pain because it hits the dorsal root ganglion, which is very sensitive. In fact, I didn't want to operate on this patient at all because of her size. She is huge, and doing an open surgery, going through the Wilsey approach and excising this particular fragment would be not only painful, it would be quite traumatic. So we gave her all kinds of analgesics, gave her bed rest, etc. But the pain was not getting better at all. And a simple solution was the slides. Yeah. So simple solution was using these tubes. This is a tube here which is going down, and can you hear me?
Yes,
Yes, we can hear you. Yeah.
So this extraforaminal area, this is the superior facet. This is the transverse process, and it is a junction of the superior facet and the transverse process. You see this disc intervertebral, this disc herniation, which is appreciated, and it is excised. It's a matter of a few minutes actually. As soon as you dock the tube and separate the soft tissue next to the superior facet and the transverse process, you see the the disc herniation here, and the size of the incision hardly about 2 centimeters, and that is the beauty of minimal access. So when it comes to spine surgeries, the old workhorses are these Cobb's elevators, these mastoid retractors, etc. And the whole thing looks quite ancient compared to what our colleagues are doing in different specialities, like they're using robotics, they're doing laparoscopic, they're able to remove thyroid glands through the axilla using ports. We feel we are quite ancient compared to them. So that is where the tubes come in. These are the new work horses of spine, and they're so versatile. You can do almost every procedure using the tubes, right from discectomy to decompression to multi-level fusions, deformity correction, etc. So these are the workhorses. What we basically do is these tubes come in various diameters and different heights, and depending on the procedure that you are planning to do, these tubes are they can be that determines the size and size of the diameter. And how do you use them? So you pass a series of dilators to separate the paraspinal soft tissue, that is the paraspinal muscles. And once you pass the biggest dilator, that determines the width of the tube that you're going to use and the height of the tube that you're going to use. And this is a temporary port. As soon as you remove the tube, that the tissues fall in place and there's hardly any dead space, and this has a clear advantage which I'll be talking about later on. So this is an example. This is where this is a patient with a significantly big disc herniation. You can see here it is at L4-5. He had significant leg pain. This is how your tube gets docked, and this is what you need to see when the tube gets docked. You should be able to see the junction of the medial facet, the lamina, and some part of the flavum. The tube should be such that it should bisect the disc space. It should not be in a different angle. It should be collinear to the disc. So this is how the tube is parked. So these dilators, these are the dilators, these are the tubes, these are the flexible. This is the flexible arm, and so a C arm is necessary. So the the guide wire is passed about 0.8 to 1.2 centimeters away from the midline. Depending upon the size of the patient, the dimensions differ depending upon the size of the patient and what you read on the MRI. And these are the dilators of increasing diameters, and that is these are attached to. Then the final port is attached to the flexible arm, which gets attached to the railing of the table. And this is what you see. So your localization is absolutely important. So once your tube goes in, you should be able to see the lamina as well as some part of the medial facet and the ligamentum flavum. So this is the head
Arvand.
end. If you see the arrow, and
Arvand,
this is the yes.
can you hear me? We cannot see
Yes,
the,
yes.
the video. Is it a video?
Yes, you're not able to appreciate the video.
Is it a video?
Yes, yes.
We cannot see a video. It's only black screen. It's written a procedure and the
But
black
you know,
screen.
here it is playing.
Ah, yeah. Can you try it again? Close it and then open it again?
Yeah. Did you see the previous video?
No.
No? Neither previous one. We only saw the
Yes,
we
we
only saw
know
the
that.
pictures.
Now?
Only the pictures. Only we can
Now?
see the pictures, but not the video. Yes, pictures.
Now you're able to see the video?
No, the pictures. The video is not working. The pictures of the procedure, but not a working video.
Oh, I'm sorry. This is working on my screen here.
Okay.
It could be the.
Look, we can't see now.
Now we can now we can see it, but very slow. Yes, now we can see it. Yes.
Yeah, it is
But very
it's
slow.
going very slow. Yeah,
Yes. Okay. Now we can see it. Yes. I think it's due to internet and there's some delay between. Okay. Can you try again to open the procedure?
Look, it depends on bandwidth, if it's good or not, because some of the audiences now can see the video. Others cannot because of the internet quality.
The best. Yeah, it has to do with the internet connectivity.
Okay. You can go ahead with explaining the procedure and then some pictures.
Yeah, Dr. Arvand,
Yeah.
is it possible? I think
So,
it will not.
This is. Can you see the slides now?
No, see, we can.
Yes.
Yeah.
Yes,
This
yes, we can
is
see.
in early 2014 that we published our series. So then by then we had done about 200 cases. And so the advantages are basically cosmesis. It's a very small scar, and all scars contract over a period of time. And when you're operating, the back is stretched. So when the patient stands, it's much shorter than what your earlier incision was.
Now we can see it perfectly.
And now, if you see,
Sure.
with regards to evidence, we, everyone looks for evidence-based medicine now. Is it really significant? This particular procedure, is it comparable to other modes of surgery when it comes to tissue damage? So there are various studies which show that the markers of tissue inflammation, that is interleukin 6, CRP, etc., is much lower when you do through these tubes, when you do the procedure through the tube, compared to open procedure or a microdiscectomy. Again, there is a limit to how much you can retract the root. So there have been studies which show that there is less irritation of the nerve root using these tubular retractors. So, for example, one of the this is an superiorly migrated disc. So what you need to do is you need to dock the tube exactly over the location of the disc. Hello, can you hear me?
Yeah,
Yes,
okay.
yes, we can
I think
hear
the
you, but
problem with the video.
So the disc is migrated. So the disc is migrated superiorly. You don't have to go to at the level of the disc and then go up. What you do is you dock the tube exactly at the site of the disc herniation, like we have done here. And all that you need to do is you need to do a laminotomy, which is round in structure. You don't have to go to the inferior margin of the lamina. You just make a drill hole around that area, and I'll just show you in the next slides. So this is the inferior migrated disc. So here you dock the tube on the location of the disc. You don't have to go all the way to the disc space. So in this particular situation, you don't even have to do any bony work here. Unfortunately, this video you're probably not
Arvand.
able to see.
Arvand,
Yeah.
can you make your camera? Can you make your camera off? This will get. I think if you can make your camera off, then maybe the video will work.
Okay, one second.
Okay, I will stop it. Okay, I stopped his camera.
Okay.
Can you see it?
So, not yet.
I don't know what the problem is.
Okay, so we can continue. Yes, Arvand, please continue.
Yeah.
Yeah. Because we can see now the pictures from the MRI and the X-ray.
Yeah. So so when the disc is migrated superiorly or inferiorly, all that you need to do is make a hole. You don't have to do a wide laminotomy to get to the disc. So that is the beauty of this the tubes. So this is called a translaminar discectomy. So here you see, we are using a burr. We are making a drill hole. Can you appreciate these drill holes here? So this is exactly on the location of the disc. And then you go in and excise the fragment. You don't have to go all the way to the parent disc. So if this is a post-operative CT which shows oval hole here, and over a period of time this fills up with bone. So this maintains the integrity of that particular segment. You're not playing around with the ligament of flavum. This is usually beyond the attachment of the flavum, and this bony island that you excise will fill over a period of time. This is especially important when you're doing a recurrent disc herniation. So this patient had undergone a L4-5 discectomy. This is a long incision of a previously done L4-5 discectomy. There is a lot of scar tissue. He came with a inferior migrated disc later on. And all that we did was we didn't have to go through this, previously operated tissue at all. So we made a drill hole in L5 lamina. So this is at L4, L5. Generally, when there is a L4, L5 disc herniation, it is a L4 lamina that you drill. So here you do a L5 laminotomy, making an oval hole in L5 and grab this particular fragment. So it's a very quick procedure. You don't have to go through the previously scarred tissues. Again, if the patient has discitis, just like how the endoscopic surgeons proceed, what you do is we insert the tube, and through the tube you put your pituitary in, grab the material, send it for histopathology as well as cultures, and get the organism and put the patient on antibiotics. And when you're doing the biopsy, you also give a thorough wash of the disc space, and that is possible with these tubes.
Okay, so Arvand, you have only 5 minutes left, please.
Again, the best,
We are
so
sorry
the
for
advantage of the tubes
disconnection.
is, even if there is, even if patient has 2-level or 3-level affection, using the same incision, you can tilt the tubes in to both levels and do whatever is necessary, whether it is decompression or discectomy. So using one, for example, in an obese patient, if you're doing L4, 5, L5S1 open technique, you can appreciate the difference between using the tubes and the open technique, the amount of morbidity to the patient. Again, recurrent discs can be easily managed with tubes. Case of a patient with cauda equina, whether it is a thin patient or an obese patient, whether it is a laurel or a size of the incision remains the same. And this is the biggest bone is in the patients who are obese. Obese patients, it makes a big difference with regards to the morbidity. So patients like this is a big boon. And compared to microdiscectomy, where the spikes can tear the posterior ligamentous complex, this particular part of the retractor, the tube is much safer. Whether it is a central disc herniation, sometimes if you are wrong. So suppose if you've done a laminotomy on the opposite side by mistake, the property of tube is such that you can actually angulate the tube. So this was a patient where by mistake I went to the right side. Patient had herniation on the left side. So I could tilt the tube and do the opposite side discectomy. Again, because there is hardly any dead space, CSF leaks can be easily managed with these tubes, because you just have to remove the tube, the soft tissues fall in place, and you take a watertight closure. So they hardly create any problems because the dead space is minimal when you are using the tubes. Again, doing a wrong level surgery is extremely rare and impossible with the tubes, because still the tube is docked. You're getting your shoots, and if there is a poor skin condition, again we have this paper which showed that the incidence of infection in decompression and discectomy is 0%. That is because pathogens are not exposed uh, to this, to the tissue. So over a period of time we have graduated. So over a period of time we have graduated from 18 to 16, 16 to 14 tubes, and from 14 to 12 tubes for discectomy especially. So I'm just quickly going through these slides. So this is done. This is a case where we did a discectomy using a 14 tube. So this is a large disc herniation which was tackled using a 14 diameter tube. And this is extraforaminal disc herniation. You can see this extraforaminal disc. We use a 14 long tube to remove this particular excise this particular disc herniation and free the root. So this is our first patient where we use our 12 millimeter tube. This is specially made by Medtronics for us, and it's easily possible to do a discectomy using these 12 millimeter tubes. So this was the shoulder disc.
Excellent.
Yeah.
Can you give us, like, within 1 minute, take-home message from this excellent lecture?
Yeah, I'm just running through. So we are doing these cases with local anesthesia. As you see here, this is a published paper. So I'm ending this slide. I'll just show you the last slide, which is the take-home message. Anyway, the take-home message is, it's a versatile tube. You can do a number of procedures using this tube, and there is a learning curve to it. And once you cross that particular learning curve, it is beneficial for you as well as your patients. I'm sorry, this videos had a problem today. Thank you.
Many thanks, Arvand. Excellent talk. Thank you so much.
Thank you, Arvand.
I'm so glad that you managed to have these procedures with 14 millimeters tube and 12 millimeters tubes. Now I will shift to Mohammed Badra. Hi, Mohammed.
Hi.
Hello, how are you, Mohammed?
How are you? Can you hear me?
Yeah. Your voice is not good, Mohammed.
Hello.
Okay. Hello. Yes.
Voice is not good.
Yeah,
yes.
Dr. Arvand, can you disable your sharing?
Arvand, can you end your... Yes.
So how do I do that? I think
okay, I can close the...
Yeah, it's your end.
Okay, do it, Ahmed.
Oh, he should, Arvand should close his share screen.
Okay.
1 second.
Can you manage to do it, Arvand?
Yeah, close it. I 1 second. It's taking some time. Yeah, now.
Good.
Yeah.
Yes, Mohammed, please, can you share your screen? Mohammed Badra?
Yes. Can you see me right now?
Yeah. Yes.
What about,
thank you, Mohammed. Go ahead.
What about the voice? Can you?
Yes.
The voice is not good, Mohammed.
Can you hear me right now?
Yes.
I don't know why. Can you hear me right now?
No, Mohammed.
Maybe.
Mohammed.
Yes. I can hear you very well, but I don't know why you cannot hear me.
Yes, now it's good. Yeah, perfect. Go ahead.
Now it's good. Yes. Good evening, everybody. As you know, now is the time. The gold standard for treatment of lumbar herniation is obesectomy, the form of microdiscectomy. Even microdiscectomy, the word means minimally invasive, but this technique cutting the skin, muscles before you enter the spinal canal and you herniation, and this technique has really stood the test of time and has been shown to be associated with a very clinical outcome. However, the current trend, as you heard in the first lecture, is to go as many people, and the initial idea actually started back in 1997 when Smith and Foley actually introduced the concept of tubular discectomy. So instead of cutting the muscle with muscle fibers, and then you introduce small tubes through which you the spinal and remove the herniated disc. Can you hear me right?
Mohammed.
Muzahem, you hear me?
Mohammed, your voice is
Yes.
I can hear you, but your voice is interrupted. It's not, the screen is good, but your voice is interrupted. It's not very clear.
I don't know what I can do to but, maybe because of the internet connection. You can hear me right now.
You can hear me.
Can you hear me right now?
Yes, I can hear you, but try to speak slowly. Maybe it will be better.
I will. So the initial idea actually started back in 1997. Introduced to me for and as this has been used in urgent discrimination. But the questions that came later on, this tubular discectomy is really a mini procedure. In order to answer this question, actually, Arts and his group back in 2009 published a randomized control trial comparing tubular discectomy to conventional microdiscectomy for sciatica by looking at the functional outcome, mainly by measuring the Roland-Morris Disability Questionnaire, leg pain, and back pain. And what they concluded in this article, the result and in order to sneak discectomy is associated with to microdiscectomy by measuring the CPK level at the end of the first day and by measuring the grade of muscle atrophy at the end of the first year. And what they found, there was no difference in CPK level at the end of the first tubular discectomy and between no difference in muscle.
Hello, Mohammed? Hello. We lost the connection with Mohammed.
Yes, I think he has bad connections in Lebanon.
Okay, Arvand, are you still? Hello, Arvand, are you still with me?
Yes, yes.
While Mohammed tried to reconnect again, we have some questions from participant. Sharma, he's asking about your case, the first case you present. He said, can you manage this case by selective root block, and then if this fail, you can go ahead with tubular.
So this was the third time she came.
Okay.
So first 2 times we gave her root block, and
okay.
First time it helped. Second time there was partial relief, and third time she was also fed up of injections better, but she was never completely happy with the injection.
Okay, so another question from the floor. Exactly where you dock your point? Did you depend on the direction of the disc herniation, the site? Exactly where you dock your point to start your surgery?
So we look at the location of the herniation. So suppose it is at the level of the disc, then the tube is docked exactly over the junction of the lamina and the clavum. If it is superiorly migrated, it is mostly over the lamina, the superior lamina. If it is migrated inferiorly, it will be angulated inferiorly. And if it is in the foraminal area, extraforaminal area, it is actually usually at the, so for example, if it is the L4-5 disc which is migrated, which is extraforaminal, then it is at the junction of the superior facet and transverse process of L5.
Okay. I have seen your case where you missed the site, whether it's right or left, and then you go from one on the other side.
Correct.
You put your tube and you manage to have this. Is it easy for you to get the disc?
So that is something we should not do. That should not be. It's unpardonable. It is just that we are used to doing the opposite side decompression when patient comes for surgery for lumbar stenosis. We are used to that particular approach. So in this particular situation, I had to bail out. That's why I did that. But in when you're doing your initial cases, don't get into all this. This is something which I would discourage.
Okay. Another question from the floor. Which tube did you prefer? The beveled one, the round one, the slotted one, or the complete one?
I don't have any. I always use the non-beveled
The regular one.
Yeah.
Okay. So we do we get back to no? This is the screen from Mohammed.
Yeah.
Mohammed Badra.
Yes, supposed to be from Mohammed Badra.
Mohammed, can you hear me? Hello, Mohammed. Okay, so keeping with Arvand, Arvand, are you still with us?
Yes, yes.
Okay, so I just want to ask you what participants usually want to ask. How can you manage bleeding when you deal with this tubular discectomy?
Yeah. So a very good question. It starts right from the beginning of the surgery. So positioning. So generally patients who undergo discectomy, when you're doing an open procedure or a microdiscectomy, you tend to put the patient in a little bit of kyphosis, so that you can open up the interlaminar window. I do it the other way around. I put the patient in lordosis and I keep the abdomen absolutely free. And this has come with experience. So one is it helps in reduced epidural congestion. Second is when you're doing a decompression for patients with stenosis. See, these patients get symptoms in extension, that is in standing and walking. So if you've done your decompression when the patient's back is extended, probably you've done a thorough job of decompression. So indirectly it helps in reduced bleeding because the epidural congestion is less. Second is when before I take the incision, I insert a needle. It's a 20 gauge spinal needle. It goes exactly on the location of the on the lamina, and I inject about 15 cc of saline that is diluted with sensocaine, 5 cc of sensocaine, and that decreases the bleeding when I take the incision. That makes the paraspinal muscles soft, and that also gives preemptive analgesia, preemptive anesthesia, and this also reduces bleeding. So once you start putting your dilators, the muscles become soft, and that reduces the bleeding. And the other thing is you have to see to it that your docking is absolutely on the bone. In case you are not on bone, you put your dilators once more so that you are on bone. And as you see here, the initial part of the bleeding is managed with long cautery tip. So you need to have a long cautery tip to manage your initial bleeding. And second is I always use a burr. It is very difficult to use kerosene straight away through these narrow tubes and do a laminotomy. So the burr itself is a hemostatic instrument. As you keep burring, it will keep it will keep burning the blood vessels in the cancellous part of the bone. And to control bony bleeding, every time there is a bony bleed, you use patty and bone wax, and the rest of the stuff is the same use of bipolars, gel foam, Surgicel, etc. In fact, to a certain extent, that in even those patients who are in clopidogrel, even on those patients who have aspirin, who continue to take aspirin, we don't stop it. We operate on any patient who is still on anticoagulants. And this paper is coming up in Spine in next 1 or 2 months, where the title of the paper is, does not stopping of anticoagulants, does it increase the morbidity in minimal invasive lumbar spine surgery?
Perfect. Thank you, Arvand. Mohammed, are you with us?
Muzahem, can you hear me?
Yes, Mohammed. Now I can hear you very well. Please go ahead.
Hello, Muzahem. Can you hear me right now?
Yes, Mohammed.
So,
please go ahead, Mohammed.
One minute.
You can stop share and then return back share again.
I was doing that now.
Okay, Mohammed?
I think he is disconnected again.
Again. So Arvand. Arvand. Okay, Mohammed is starting. Yes, Mohammed, yes. Mohammed, are you with us? Can you hear me?
Let me see.
Is he self-muted?
Yes, now he can.
Mohammed?
Yes. Yes.
Muzahem, can you hear me?
Yes, we can
Yes.
hear you now.
Yes, Mohammed. Yes, Mohammed.
Can you
Please.
hear me right now?
No, yes. Okay.
Okay. So a meta-analysis study, I was talking about the tubular discectomy in comparison to microdiscectomy, and a meta-analysis study published by the Johns Hopkins group back in 2012, comparing the two techniques, tubular discectomy to microdiscectomy, that included 6 randomized control trial and more than 800 patients. Actually, when they compared the two techniques, tubular to endoscopic, when they looked at the results, the operative time, reoperation rate, total complication, VAS score were similar between the two groups. The only difference was in the incidence of dural tear. The incidence of dural tear was significantly higher in patients who had tubular discectomy. So all these studies, they actually failed to show the big advantage of tubular discectomy over microdiscectomy for treatment of lumbar disc herniation. And as you know, in the past 10 years, there has been an increased interest in using endoscopic discectomy for treatment of lumbar disc herniation. Muzahem, you can hear me right now?
Yes, Mohammed, go ahead.
So in the past 10 years, there has been an increased interest in using the endoscopic discectomy for treatment of lumbar disc herniation. And this technique can be done, as you know, in 2 ways, either the interlaminar or the transforaminal approach. And as the name implies, the interlaminar approach, it means that we have to go in between the lamina in the interlaminar window in order to access the spinal canal. And the transforaminal approach, we have to go through the foramen in order to access the spinal canal and remove the herniated disc fragment. Which way to go, interlaminar or transforaminal, actually depends on several factors, mainly the anatomical limitations of the segment you are working at. It depends on the level of the disc herniation, because in L2, L3 disc herniation is approached in a different way from an L5S1 disc herniation. The location of the disc herniation, for example, a centrally located disc herniation is approached in a different way from a preforaminal or foraminal disc herniation, and it depends also on the surgeon experience, because some people are really expert in the transforaminal approach, that they can do any disc herniation using the transforaminal approach, and some people prefer to do the interlaminar approach because they are expert in the interlaminar approach. Anatomically speaking, as you go down in the lumbar spine, the size, as you know, the size of the interlaminar window becomes bigger, while the size of the foramen becomes smaller. So anatomically speaking, the biggest interlaminar window is at L5S1, which makes the interlaminar approach easiest at L5S1. So if you want to start an endoscopic discectomy using the interlaminar approach, you have to select a patient with a large window at L5S1 in order to start your learning curve. For the transforaminal approach, it depends on the, as I said, on the foraminal window, and it does not depend only on the bony window, which is the size of the bony foramen, but also it depends on the soft tissue window, which is manifested by the Camden triangle. As you know, the foraminal window is not an empty space. It has the exiting nerve root, it has many vessels, and it has a ligament. You have to understand very well the anatomy of the foramen before you put your scope there and start doing endoscopic discectomy. The indication for the interlaminar approach are all types of in-canal disc herniation. So as long as the disc is within the canal, you can do interlaminar approach. It's easiest at L5S1 because you don't have to remove any bony bone. At L4, L5 is a little bit more difficult because it has a narrow window. If it has a wide interlaminar window, you can go ahead and do it without bone reaming. But if you have a narrow window, then you have to do some bone reaming to enter the spinal canal. At L3, L4, because you have a narrow interlaminar window, most of the time you have to do some bony work in order to be able to widen the interlaminar window and go inside the spinal canal. The transforaminal approach is considered the universal approach because if you are expert in the transforaminal approach, you can approach or you can do any type of disc herniation. Of course, there are certain limitations. Like if you have a high iliac crest at L5S1, it will hinder you going at the appropriate angle at L5S1. And if you have a migrated disc, up migrated or down migrated, you need to have certain skills, technical skills, before you start doing these cases in your practice. Let's go step by step in each one of these techniques. For the interlaminar approach, the way we position a patient is this way. We flex the patient a little bit in order to flex the hips and the knee in order to open the interlaminar window. Then you start marking your entry site, usually under AP view. I go just lateral to the midline at the site of the disc herniation. I make a small incision, like less than a centimeter incision, 7 millimeter incision. Dilator. This is the only dilator that I use, and then I put my working cannula, and put my scope and start working. And these are all the steps that you have to do. It takes less than 2 minutes just to put your scope in. Let's take an example. This is a 36-year-old male patient, one of the earliest cases that I have done with a down migrating L5S1 herniation. When you put your, you can see the video, right, Muzahem? Can you see the video?
Yes. Okay.
So you start and you identify the ligamentum flavum. You start opening a window in the ligamentum flavum. As you see here, to enter the spinal canal, you start widening your window to reach the to identify the nerve and the herniated disc. Usually you see the epidural fat and you start removing the epidural fat. The white structure that you see here is the nerve root. This is the S1 nerve root. And then you go lateral to the nerve root and try to release the adhesion between the disc and the nerve root, and you remove the herniated disc fragment. This is the nerve root that I'm pushing medially, and the disc herniation is just under the nerve root. Sometimes you have to remove the whole fragment with the scope with the whole fragment in order to be able to remove it from the working cannula. You can see the video, right, Muzahem?
Yes, exactly.
Okay. And the patient will get only one stitch. This is a one-stitch surgery, and the patient can be discharged home in the same day. I don't usually like my patient to sleep inside the hospital. It's a one-day surgery. They get the surgery and they go home in the same day. For the transforaminal approach, as you know, it depends on going in the intervertebral foramen in order to be able to get access to the spinal canal. And here you have to land, you put your approach needle at the Camben triangle. As I said, you have to understand very well the anatomy of the Camben triangle and the anatomy of the foramen in order to be able to do this surgery. I start also by making my marking line under AP view and under lateral view. Usually the intersection between the midline of that disc and this is the AP view, and the lateral view, usually I take it the posterior, the facet line. I put, and the intersection between these two lines make my entry point. Usually I start by putting a needle, an approach needle under AP view. I reach the facet and I go anterior to the facet in order to access the spinal canal. On the AP view, when the tip of the needle at the medial pedicular line, the tip of the needle on the lateral view should be at the posterior vertebral body line. This tells you that I am at the middle of the Camben triangle. You don't have to bypass the medial pedicular line under the AP view. So I put a guide wire, I insert my guide wire under AP view, of course, remove the needle, and then put the dilator inside, push it under AP view, push my dilator in, and then put my scope in and start working. I push my scope inside the foramen and put my scope in and start working. Let's just give you an example. This is a 32-year-old male patient with a left-sided L4, L5 disc herniation. This is a pre-foraminal disc herniation. This is ideal for the transforaminal approach. You can do it interlaminar approach, but this ideal, it's easier to do it through a transforaminal approach. When you put your scope in, you see 3 layers. The upper layer is the spinal canal, is the epidural space. The middle layer is the ligament, is the annulus with the posterior longitudinal ligament, and the lower layer is the disc itself. And as you can see, I use a radiofrequency ablation just to identify the structure. I'm working here inside the disc, and you can see the disc here. This is a herniated disc fragment. You can see it, right?
Yes.
Okay. So you just do some release, and you grab the fragment and take it out. And you can have it as a 1 fragment or as 2 fragments. And the patient also gets a stitch on the side of his back, and he's discharged home on the same day. Always, all my patients who get endoscopic discectomy will be discharged home a few hours after the surgery. This technique has actually shown a very good clinical outcome, very good results comparable to microdiscectomy, to tubular discectomy, using the visual analog score and the SF36 score. And the question that came later is endoscopic discectomy is really a minimally invasive procedure. You remember the first study that was done by Art by measuring the CPK level, comparing tubular discectomy to microdiscectomy. This author from Turkey, actually, he did a similar study by measuring the CPK level at the end of the first day, comparing endoscopic to microdiscectomy. And what he found that the CPK level was significantly lower in patients who got endoscopic discectomy compared to patients who got microscopic discectomy. Many of my colleagues asked me why you're doing endoscopic discectomy. The regular discectomy, the conventional microdiscectomy works well for all of us. I mean, it has been associated with a high success rate, low complication rate, short hospital stay, fast recovery. All my colleagues who do endoscopic microdiscectomy, I mean, they have very good clinical outcome, and most of them, they discharge the patient home in the same day, same as I do. I think the advantage of the endoscopic discectomy is to avoid what's known as the post-discectomy syndrome. How many of us have seen patient coming after microdiscectomy complaining of persistent back pain and leg pain? You do an MRI for them after the surgery, you don't find any recurrent disc herniation. This is what's known as the post-discectomy syndrome, epidural scarring, radiculitis, arachnoiditis that are associated with the microdiscectomy technique. Why endoscopic discectomy? Because it's associated with a minimal tissue trauma, minimal blood loss, reduced post-operative pain, no wound complication, easier on obese patient. In obese patient, actually, the working cannula is stuck in the fat, and you don't have to hold it. I mean, it's much easier on obese patient. No long-term complication, no instability, no scarring, no muscle injury, and the most important, higher patient satisfaction. William Mixer, who's considered the father of disc surgery, actually predicted this more than 60 years ago. He wrote in his article that the usual dorsal interlaminar approach and the technique for discectomy cannot be the final solution for treatment of discal herniation. This author actually, he predicted that the traditional way by which we are doing disc surgery should change with time. There should be a way that allows us to access the spinal canal with minimal injury to the surrounding muscles and surrounding structure. These two patients, believe me, they had the same pathology, L5, S1 disc herniation. The patient on the left received a microdiscectomy. He's an obese patient, received a microdiscectomy by one of my colleagues. He presented with persistent back pain and leg pain. Did an MRI for him, only fibrosis. And the patient on the right received endoscopic discectomy. They had the same pathology. For sure now, still the gold standard for treatment of lumbar disc herniation is microdiscectomy until now. But I think the future is for minimally invasive surgery. And endoscopic discectomy is a promising technique to treat patients with such a pathology, disc herniation. Thank you.
Thank you, Mohammed, for this comprehensive talk. I have just one question for you before I shift to Ghazwan, because this is a webinar about two techniques, and we have to have like a summary or a take-home message to compare both techniques. So, Mohammed, how frequently nowadays in your daily practice you use endoscope to treat discectomy for the lumbar spine, and how frequently you use tubular discectomy? I mean, in your daily practice, and what's your recommendation for us?
Yes, as you know, endoscopic discectomy has a certain learning curve, a long learning curve that you have to go slowly. Actually, when I started my practice, when I started doing endoscopic discectomy, usually I started with easy cases just to go slowly in the learning curve. So I used to have only 20 to 30% of my practice endoscopy, like 70% microdiscectomy or tubular discectomy. Then with time, after case after case, as I learned the technique and the tips and the tricks of endoscopic discectomy, nowadays my practice is like 95%, 97% endoscopic discectomy for the disc herniation, and like only less than 2 to 3% microdiscectomy or tubular discectomy. I use the tube only for multi-level stenosis. Even for one-level stenosis, lumbar stenosis, I use the endoscope, the stenososcope, to do endoscopic decompression for lumbar canal stenosis. They have like 3 levels just because it saves time. I use the tube for like 3 level. If I want to do 3 levels like lumbar decompression, so I use the tube. But for 1 level stenosis and for all disc herniation, I use endoscopic technique.
Many thanks, Mohammed. Let us just, Mohammed, can you end sharing screen? Yes, Mohammed, can you end sharing your screen? Let us go to Ghazwan. Ghazwan, please. Just
stop share. Okay.
Okay, Ghazwan, can you hear me? Ghazwan.
I think he's not here.
Okay. Can you unmute Ghazwan, Ahmed?
But I can't find him. I think he's disconnected.
Disconnected. So let us go back to Mohammed. Mohammed, can you hear me?
Yeah, of course, I can hear you very well.
Okay. There's another question from the floor. How frequent your revision rate for recurrent disc after endoscopic discectomy and for incomplete discectomy?
Yes, this is a very good question, because
these two pathologies. Yeah.
Yes. Let me answer the first question. Actually, the rate of recurrence after endoscopic discectomy, if you take the literature, the rate of disc recurrence after endoscopic discectomy is the same as the rate of recurrence after microdiscectomy. And this study has been published by many authors, especially by Sebastian Rutten from Germany. But look, at the beginning of the learning curve, the most common, let's say the most common complication, as I say, is incomplete decompression, especially for the transforaminal approach, because the transforaminal approach is a new approach for us as a spine surgeon. We are used to look at the spine from the interlaminar window rather from the transforaminal window. So you put your scope initially in, and you start looking for the herniated disc fragment. You don't find it. You go out, and most of the cases that you don't say recurrence, but I say incomplete decompression. So incomplete decompression is one of the complications, but the recurrence rate after a successful endoscopic discectomy is the same as a recurrence rate after microdiscectomy. is the second question, if we can use endoscopic discectomy for revision cases. Yes, as you go up and you go up in the learning curve and you start becoming more experienced with endoscopic technique, you can do endoscopic discectomy for revision cases, especially in cases when the patient presenting to me like with the previous surgery, interlaminar open, interlaminar or tubular, and he had a recurrence. Then I go through the transforaminal, which is considered a version route for me. So it gives me a version approach with minimal complication instead of going through the adhesions. But even if you have a recurrence, I want to go through interlaminar approach, I can still go through the interlaminar approach endoscopically and remove the herniated disc fragment. I don't know if I answered your question.
Yes, perfect, Mohammed. Thank you. I have a question from Dr. Yunus about how frequent you shift your plan intraoperatively. For example, if you are planning to do endoscopy and then intraoperatively you shift to tubular. And this is also the question also for Arvand, because is it happened to him that he shifted from tubular discectomy to open discectomy? Let us start with you, Mohammed, first.
Yes. Look, I always, at the beginning of the learning curve, I used to tell my patient, look, I will try to do it endoscopically. If I fail, I will shift to microdiscectomy. But most of the time, if you are persistent, you rarely shift to open technique after endoscopic discectomy if you plan your way very well. I remember that I have done it only in 2 cases. One of them is a calcified disc herniation where I didn't have the proper tool to remove a herniated, a calcified disc, and then I had to go to a tubular. And in another case, I went through a transforaminal and I was able to, it was a migrated disc herniation and I was not able to remove the herniated disc fragment, which is migrated. Then I have to shift to a tubular discectomy. So rarely, if you plan your way very well, rarely you shift, but you have to prepare yourself to a shift to another technique if you fail to remove the disc fragment.
Okay, so I have a question for you, Mohammed, because before I shift to Arvand, this is a question from Mohammed Al-Shara. What about the disc herniation at higher levels, like above bulb for interlaminar and foraminal approach?
Higher level, you mean L2, L3, and higher level? Look, as I said,
yes, exactly, because
yes, as I said,
I can hear you.
For the interlaminar approach, it's easier. The bigger the interlaminar window, the easier the approach. So L5S1, most of my L5S1 disc, I do interlaminar approach. L4, L5, I can do interlaminar, I can do transforaminal. Higher up at for example, L3, L4, and L2, L3, the interlaminar window becomes very small. So if you want to do interlaminar, you have to widen the interlaminar window. So you have to do some bone bearing. So most of the time for L2, L3, and L3, L4 disc, I go transforaminal. And usually you have to use the posterolateral approach, because for the transforaminal, you have the extreme lateral and you have the posterolateral approach. So for the L2, L3, and L3, L4, I go the posterolateral approach and to remove the herniated disc fragment. You know that this technique can be done even for the thoracic spine, but for the higher lumbar spine, most of the time I go transforaminal rather than interlaminar.
And for higher approach, for the posterolateral approach, yes. Sometimes if you have a central disc, how can you reach the central disc? Because you will target the disc and not the what you have shown us the 3 window.
The more centrally located, the more centrally located the disc, the more centrally located the disc, the more extreme lateral you have to go. So, but look, there is one problem for higher levels that if you go extreme lateral, you might hit the the intra-abdominal structure. So you have to take care of it. So I will go a little bit. I will a compromise between posterolateral and extreme lateral, and then I try to push my scope anteriorly in order to be able to remove a centrally located disc herniation. Usually, these cases are rare at a higher levels, and the treatment of centrally located we'll discuss because the first case that you presented is a debatable case for a centrally located disc herniation. We will discuss it in a minute when you discuss the technique or the solution for the case. But most of the cases, a centrally located disc herniation is approached in a more extreme lateral approach.
Yes, Thank you, Mohammed. I have a question, another question from Floor. They are asking about patient satisfaction after endoscopy.
This is, I mean, people who are this is they always say this is a magic, because the patient goes in, especially when the transforaminal approach. I used to do them under local anesthesia. So the patient goes in with severe radicular pain in his leg, got like local anesthesia, put the transforaminal approach, takes the herniated disc fragment. Even when they are on the table, they can feel that they have no more pain in their leg, and they can be discharged home on the same day. I mean, the beauty of this approach, the endoscopic technique, is that it's associated with a very high patient satisfaction rate. They go out of the hospital with no back pain and no leg pain, with only one stitch on their back.
Would you use local anesthesia for every case transforaminal approach?
No. I mean, at the beginning of the learning curve, I used to do them under local anesthesia just to get some feedback from the exiting nerve root, because I was afraid from the exiting nerve root. But with experience, I mean, it became you know how to put your needle in, how to land exactly at the Campan triangle, and how to avoid the exiting nerve root. For patients, I mean, nowadays it's much easier for me to do it under general anesthesia, because it's quicker for me and the patient doesn't move. Initially, I used to do them under local anesthesia, but now most of my patients will get general anesthesia.
Okay, one last question for you, Mohammed. How would you manage dural tear endoscopically? On which basis you decide to shift from endoscope to open or to tubular if you develop a dural tear?
I think you remember we were together in Egypt when I presented several cases of dural tear. With the transforaminal approach, you don't have any problem with the dural tear. I mean, you don't have a dead space. With the endoscopic discectomy, you're not afraid of CSF leak because there is no dead space. You're afraid of rootlet herniation. When you have a dural tear and there is a rootlet herniation through this tear, the patient might come back with a recurrent leg pain. So with the transforaminal approach, if I have dural tear, I will not do anything, believe me, because none of my patients who had dural tears, they complained of CSF leak. For the interlaminar approach, I mean, if the dural tear is a little is small, and there are some techniques how to repair it, and this has been published. And I used the only 2 cases that I got dural tear with the interlaminar approach. I used the Duragen and Tutu patch in order to just seal this.
Hello there.
And it's a small defect, and it worked well. None of my patients had CSF leak or recurrent pain. But if the dural tear is large, then you have to shift to tube, put a tube, and stitch. Put a stitch on this dural tear and put a Duragen. This can be, you can deal with this complication as you go up in the learning curve with your cases.
Okay, Ghazwan, please share your screen. And Mohammed, we have one last question from Floor. Can you manage calcified disc, chronic calcified disc endoscopically, Mohammed?
Yes, of course. There are some burrs that allows you to burr this calcified disc. Initially, when I didn't have all the instruments, so one case I had to shift to tube, but nowadays with more sophisticated instruments, you can do some burring, and you can decompress the nerve root using these burrs endoscopically. You don't have to shift to open technique, of course.
Perfect. Yes, thank you, Mohammed. Yes, Ghazwan, please share your
Are you hearing me? Sorry for interruption because of the internet. So I will give you the case solution, what I did in the first case, which was the 2-level. This is the first case, male, 25 years old.
We cannot see. Share the screen. We can see only your picture, your face, but not your screen. Share your screen, please. Yes, Ghazwan? Arvand, Are you with us, Arvand? Can you hear me, Ghazwan?
He's there, but he can't hear you. I don't know why.
Can you just unmute Arvand?
He's already unmuted.
Arvand, can you hear me?
So, Ghazwan, hurry up, please.
Yeah, it's okay. Now it's okay, the screen?
No.
No, not yet.
The presentation,
No.
you want the presentation on the screen?
Yeah,
Sure.
No, this is only your picture, Ghazwan.
So share the
I think
presentation.
it's enough. Yep, okay.
Yeah.
It's okay now?
Yes, okay.
So this is the case, left-sided
Please,
left.
Ghazwan, nothing seen, only blank screen, white blank screen.
Now it's okay?
No.
Share the presentation, not the white screen, not the whiteboard.
Yeah, I just shared the presentation, not only the white screen. Now it's okay?
No, only white screen. No.
Now?
No, we cannot. Okay, so Ghazwan, because for the sake of time, can you just summarize to us what you have?
Yeah, what I did in the first case, we have, as we know, we have two level left-sided 5S1 and right-sided 4-5 with foot drop in the right side. Actually, I did this case about 1 year ago. I entered the two-level tubular, one level of the 4-5 with the 18 mm tube in the right side, and then I shift to the left side, doing at the level of the 5S1 with from the left side. This is the first case that I did, and for the second case, which was the case of L4-5 migrated disc, I did the tubular discectomy from right side at the level of the 4-5.
Okay. So Ghazwan, what's your take-home message from these two cases?
Yeah, my take-home.
So the first case was two levels. So what's your take-home message from these two cases?
For this case, it's two level and on both sides. So 4-5 at the level of the 4-5 on the left side, right side, and the 5S1 at the level of 5 left side. So my take-home message here, although it's two level, there is a rule for MIS, but as Dr. Arvand, we can do, might be personally in the near future, we can do on the same entry point, say semi-tube. So this is two-level cases. While in the other case, it's lower migrated disc, which I think let's say limitation of endoscope, although as a beginner. So tubular microdiscectomy also give good solution. One important point that Dr. Mohammed Badra highlighted and Dr. Arvand. Personally, I started to do a tubular 3 or 4 years ago. I didn't feel any difficulty to start with, so my learning curve was let's say very low. I just started a few cases, and then I'm doing, let's say, discectomy, decompression, multiple level of decompression, bilateral decompression in the tube. While when I returned back from Korea, I started to do UBE technique, which is unilateral laminotomy bilateral decompression by using biportal endoscope. The problem that I feel some difficulty in the beginning, especially the bleeding, so I shifted to tubes. Till now, I didn't practice or started the endoscope. Might be in the near future, but I think from my perspective that the learning curve of tubular it's much more easier than for endoscope, and the scope of indication also wide varieties of pathologies started from disc, let's say decompression, stenosis, even for pyogenic infection, as Dr. Arvand said. And I don't have any experience in endoscope to give my opinion. Thank you, Dr. Muzahem.
Thank you, Ghazwan. Many thanks for you. Arvand, are you with us? Arvand?
Yes.
Arvand, please. Now we heard this is a discussion between two techniques, the tubular discectomy and the endoscopic discectomy. And we have heard from Badra that he started his experience with the tubular and then he shifted gradually to endoscopy, and nowadays he did more than 95 or 97 of his cases by endoscope. So what's your personal experience? Do you still do tubular more than endoscope, or you prefer to an endoscope?
I've never touched an endoscope.
Okay.
So I'm extremely happy with the tubes. I mean, it's an experience of about 13 years.
Okay.
So most of the conditions I can handle with the tube, including intradural pathologies once in a while. And so unlike all the theoretical disadvantages which Dr. Mohammed spoke about, even here there's hardly any scarring, there's hardly any post-operative radiculitis, whatever. And it is a very elegant instrument, the tube. You go in, come out without causing any morbidity to the patient.
But we have heard that there is more scarring, more fibrosis, more back pain. What's your experience?
So this more is a very relative term, So here there's hardly any scarring. You go in, you go out. You are separating this paraspinal muscle fibers alone. And most importantly, this is a versatile tube. So if you have a disc, you do a discectomy. In next case, with the lamina, stenosis, you do it with a tube. And you have another TLIF, when you use a bigger tube. So all the time you are using these tubes, so you get comfortable with this, and that is reflected in the patient's improvement. It's not just a question of you doing it. If the patients don't complain, they're happy about it, and the same word magic which you use in endoscope, even our patients that they call it magic. The way there's hardly any post-operative morbidity, there's hardly any post-operative pain at the site of the incision. So it also again depends upon where in your learning curve you are. In the initial practice. So I was very lucky, because when I started practice, I had I did not have a big learning curve after I started. I was well trained before I started doing my first case. So probably when you start doing initially you have complications. I think the best way to avoid getting complications and cross your learning curve fast is to work with an experienced surgeon. Do at least for 2 to 3 months, and I think that gives a good headway.
Okay, perfect, Ahmed. And one of the participants asked you the same question that he asked to Badra. Did you ever change your plan intraoperatively from tubular discectomy to an open discectomy? Like open surgery?
I remember only one case. Yeah. Initial practice, I had a massive dural tear, and I was totally petrified. So my first reflex was to open and sort it out. But after that, I've never had to do this.
Thank you, Arvand. Thank you very much. Mohammed, did you have something to add? Mohammed Badra?
No, thank you. If anybody has any question, I'll be happy to answer.
Thank you, Mohammed. Any question from participants? I haven't seen any
question. Can I ask question, please?
Yes, Ghazwan, please.
Yeah, for Dr. Mohammed, if you see the case, the first case, the 2-level, what's your opinion to do? Interlaminar or transforaminal?
you know, the first case that you presented, Ghazwan, is a, you know, if you look at the disc at L4, L5, it's a kyphotic disc, and it's a centrally located disc herniation. If I want to do it, if I want to do this patient endoscopically, for sure I will do him, because the centrally located disc, I will do transforaminal, but I will tell my patient, look, this is a case with a high recurrence rate. The patient has to know that this case is associated with a high recurrence rate. Even if you do it open or you do it endoscopically or you do it tube, it's associated with a high recurrence rate. And if the patient is old, I mean, this patient was young, 25 years, I remember. But if he was old, I would do, I will fuse him. But if I want to get only a discectomy on him, I will do transforaminal L4, L5 endoscopic discectomy, of course. With I will watch him for any recurrence. You know, central located disc herniation, kyphotic disc. I will be worried about the treatment of this patient.
What about the 5S1? You will approach it from other side?
Which one? You're talking about the first case?
Yeah.
Look, if I have a 2 disc herniation, and I have presented in some of the conferences, I think Muzahem watched me, I have several cases with a 2 disc herniation. So if I have a patient with an L4, L5 and L5S1 disc herniation, I want to approach them. Most of the time, the L5S1 will get it interlaminar approach, half an hour, and the L4, L5 will get the transforaminal approach. L5S1, I like to do him interlaminar. L4, L5, I like to do him transforaminal. And I have several cases that were treated this way. 1 stitch for the interlaminar, 1 stitch for the transforaminal.
Thank you, Mohammed. Thank you, Ghazwan. Since no more question, I can just summarize that my take-home message from this webinar, that the tubular discectomy is still now is the gold standard. But there's a lot of evidence supporting the endoscopy, and it's worthy to learn. And in the future, I'm sure that there will be a lot of more papers supporting the endoscope. So I think the take-home message for all of us, learn more about endoscope, and we hope that the future will be better for us and our patients. Thanks a lot. At the end of this webinar, I would like to express our deep thanks and appreciation to all our guests and participants for being with us, and hope to meet you soon in other webinars and activity. Thank you so much.
Thank you.
Thank you. Thank you very much.
Thank you.